Good morning. It's my pleasure to speak about how to ventilate obese patients in this ERDS day. I'm Samir Jaber from Montpellier, France. And I propose you in the next 50 minutes to try to discuss with you 10 tips about obese ventilation RDS patients. So, management of obese patients with RDS, the main message are now around 20% of all patients admitted to ICU are obese. The obese patients are at high risk of developing lung recruitment and then atelectasis. The incidence of RDS is increased in obese patients. We will see what in this specific population we have an increase of RDS prevalence, probably due to a high tidal volume set by clinician related to weight and not to height. Surprisingly, similar or lower mortality risk when compared with non-obese patients with IRS we observed in obese patients. So another key element considering the relation between obesity and IRS is that the clinician might consider obese patients to be at high risk of worse outcome. This belief could result in early admission to the ICU, increased monitoring associated with increased use of prophylactic measures could then explain the better prognostic observed in obese patients. I will try to summarize you very early in my presentation the main message, and I perform this table to try to summarize the similarities and the main discrepancies between the management of RDS non-obese patients in comparison to RDS obese patients. I try to summarize the 10 major points that we try to set in this situation. First of all, the ventilatory mode. Today, we have absolutely no difference between volume control and pressure control mode. So volume control is recommended for his safety use because it's very easy to measure the plateau pressure. We will see this in detail in the next slides. The tidal volume should be set at 6 milliliter per kilogram of ideal body weight, not real body weight, but ideal body weight according to the height of the patient. We will see also a slide which summarizes major point. The respiratory rate, it's also in the same way, and we should really try to avoid the autopipe, so then we will increase the respiratory rate until we obtain a zero flow in the expiratory flow and zero pressure in the airway pressure. The plateau pressure usually is considered to be safe less than 30 centimeters of water. So this is a particularity of obese patients because in some cases, probably we should tolerate more than 30 centimeters of water. We don't have clear data about what should be the value of plateau pressure in obese patients. This is sometimes complicated because all obesity is not the same, and we need to have the evaluation of the mechanic respiratory of the patient, and then we could use esophageal pressure as a surrogate of pleural pressure, and then probably it will be interesting to have this monitoring in this patient. Also, to try to set the p-value individualized in each patient. The p-value is considered to be moderate to high levels, between 5 to 15 centimeters in non-RDS patient, depending of the severity of the patient. But probably and certainly we have some strong data, some physiological data suggesting strongly that high level of PIP could be used in RDS patient, probably above 15 centimeters water. But the main message will be that you should individualize the PIP level for each patient. Recruitment maneuver is till today not recommended systematically for non-RDS patients. In contrary, in RDS patients, it's recommended because we have different approaches in this situation. Prone position is recommended both RDS and non-RDS obese patients, obese and non-obese patients, and especially in severe hypoxemia patients. We don't have strong data about the prone position in terms of outcome in obese patients, but we have strong physiological data. Upright position is also recommended. The same is true for the neuromuscular blockade and also for the ECMO. This slide, I think that summarizes the majority of the difference and the common point. So, as said in the previous slide, there is no single obesity, but several obesity. That may explain in part the controversies results of some study on obesity, because we have now one third of papers show that the obesity is a risk factor of mortality in ICU. Others showed a neutral results, no significant difference, and other suggested that obesity could be a protector, and then called is a paradox obesity. So probably the future is a personalized medicine, because you see, for example, a woman and a man had a different, clear difference of their obesity. You see that you have here a genoid one obesity, and here is underweight. You see the distributions of the obesity is not the same. One looks like a pear, another looks like the apple. This may explain some difference also for the modification observed in the respiratory mechanism and the respiratory function of the patients. Pre-oxygenation is easy. Obesity is a risk factor for difficult mass ventilation and intubation. And you have this paper showing that the Macocha score is also available for to try to discriminate who will be risk factor, who will be at risk to be intubated. You see a patient with Mallampati score 3 or 4, the reduced mobility of cervical spine, and the obstructive sleep apnea are associated with difficult intubation. So recently, some studies suggested that compared with direct laryngoscopy of the Macintosh, video laryngoscope significantly increased the rate of tracheal intubation on the first attempt and provided a superior glottis view with no increase in complication. This is a surrogate of the condition of intubation. This should be considered in the future in your unit to have the video laryngoscope with a skilled team. I said the ventilatory mode is really no difference. As you see, if you have a setting with the same driving pressure, please always compare plateau pressure when you use volume mode with the Pmax in pressure mode. You should not compare Pmax of volume control versus Pmax in pressure. It's probably some mistakes made by some data reported. So check volume and check pressure. When you are in pressure mode, check volume. When you are in volume mode, check plateau pressure mainly. So today, the volume control mode is recommended for the majority of the societies because the simplicity and the safety to use. However, in volume control mode, please, it's recommended to set the inspiratory flow at 16 liters per minute, what it means 1 liter per second or more, to provide enough inspiratory flow in case of the patients have an inspiratory load and is awake. Tidal volume, it's very easy to remember that it could be set according, as you see here, the height and not the weight. And in a simple way, you understand that you see these two patients, one is a patient with obesity and the other is patient without obesity. You see that the lung volume are very similar if the height is the same. So to calculate the ideal body weight, you can use a simple formula I recommend you is the height in centimeter minus 100 for the man and height minus 110 for the woman. This is a sample, but please consider in obese increase PEEP because as you see, you have the retentissement of the thorax and this modified the mechanic ventilatory. So, as I said, development of ALS increased significantly with increased weight. This is reported in several studies. One of the first is from the group of Kang and collaborator, showed that obese and severely obese patients have a high incidence here of to develop ALS. And surprisingly, again, this is a paradox because RS obese had a lower ICU mortality in this trial, but this may be due in part of the higher mortality in the underweight patient explained by the authors of this. So, pressures. What pressures could be for interest? Major concept for lung protective ventilation in patient is try to avoid derecruitment and to avoid surdistension. As you know, if you use a low PEEP, you have probably no hyperinflation, but you have development of atelectasis. In contrary, when you have a high PEEP, the risk is to have hyperinflation like this, but probably no atelectasis. So probably each patient should have an individualized PEEP, which is called personalized medicine. One way is to try to have esophageal pressure and try to monitor the transpulmonary pressure to have a positive transpulmonary pressure with the Daniel Telmore technique. Another is to use the impedance symmetry, which is a non-invasive monitoring of lung aeration. Using this strategy in some situations, such in surgery using laparoscopy, the other reported in several situations by IIT that 80 centimeter could be one of probably the value could be considered as the reference. The same was found in bariatric surgery. You see, you have more than 20 centimeters. This study not recommended to use this value, but give us some physiological point that probably the PEEP value in obese patients should be slightly or more higher than in non-obese patients. However, the driving pressure, as you know, is reported that it's a surrogate of the mortality in ICU patient with ALS, reported in this study that we find, unfortunately, in non-obese patient, it's correct, as you see here, the difference between the mortality and the non-mortality patients. And in non-obese patient, we have no significant difference as shown in these two Kaplan-Meier curve. This is the non-obese patients, and we use the 14 centimeter of water for driving pressure. And this is the Kaplan-Meier curve for the obese patient and showed no significant difference. Recruitment maneuver, as you know, is recommended. You see, you have PEEP alone, recruitment alone, and PEEP plus recruitment. So using PEEP alone or recruitment alone could not allow to avoid the atelectasis. However, using both, that means open the lung and keep it open, could avoid atelectasis. The position, it's recommended, very recommended to use setting position, that means position between 30 and 45 degrees in the obese patient. Like in the non-obese patient, this bet is have another benefit than prevention of lung infection, but you have in this position, more than 30 degrees, a decrease of the expiratory limitation flow and the decrease of autopipe that the PEEP intrinsic, as you see in this nice study. Prone position is, today we have several data showing that it could be useful. In this trial, we reported that the improvement of PF ratio as a surrogate of the oxygenation increased significantly more in obese patients than in non-obese patients. And in a skilled team, it could be safe to use it easily. And one of the major action is probably the recruitment, as you see this in supine position. In the green part is the normally aerated part of the lung, and in the red part is the atelectasis. After 12 hours of prone position, this is the personal data, we showed an increase of the normal aerated green part of the lung and the decrease of atelectasis, which means recruitment alveolar using the prone position. So the winning, you should consider PSV 0 and PEEP 0, that means very low pressure, and the TPs, that's best. You could consider non-invasive ventilation, both probably CPAP or NIV after extubation. Probably we should consider in some case high oxygen flow therapy. So the take-home message is difficult intubation is absolutely a major point, and it should be anticipated and optimized for oxygenation using NIV or Optiniv, which is a combination of high flow oxygen with non-invasive ventilation. The volume mode is we have no superiority of one in comparison to others. So it considered recommended to use a volume control mode for its safety. Tidal volume should be set according predicted body weight and 6 milliliters per kilogram of ideal predicted body weight. You should consider a higher PIP than in non-obese patient, and this is true is more severe ADS, that means more hypoxemic. Recruitment maneuver is recommended in comparison to the non-obese patient. Prone position is useful in severe patients with a skilled team. Spontaneous breathing trial for extubation should be used by T-tube or PSV0 or PEEP, because if you use PSV at 7 or 8, you probably not have the good evaluation of what we will do the patient after extubation. And finally, consider after extubation ventilatory support, both high flow and or non-invasive positive ventilation. Thank you very much for your attention.